will be loss of smell. There will be changes in normal swallowing mechanism. There will be changes in the pattern of respiration, and of course, what we have gathered here to talk about, the loss of speech. How is speech affected? See, speech gets affected because our lungs, they act as bellows, the larynx, it acts as vibrators, and the mouth, tongue, teeth and lips, they act as articulators. So any changes in the articulator can also affect speech, any changes in bellows can also affect speech, and of course the change that we are talking about here is larynx. This is the main vibrator which actually produces a sound which eventually translates into speech. So for normal phonation, we need good respiratory support, adequate glottic closure, normal mucosal covering of the vocal cord, normal movement of the body on the cover of the vocal cord, and of course adequate vocal length and tension control. All of us know about the glottic cycle. There is one opening and closing of the glottis, which makes one glottic cycle. So there are mainly two phases in the glottic cycle. So before we understand about rehabilitation, we should understand what normal physiology is. So there are mainly two phases. One is the open and the closed phase. In the open phase, what happens that the vocal cords, they move away from one another. In the closed phase, they come towards each other. So the main vibration of the fold occurs during the closed phase when the air tries to escape through the glottis. So this leads to three types of vocal vibratory patterns: falsetto vibratory pattern, modal voice pattern, and a glottal fry. Modal voice is the normal voice at which we speak. So everyone will have their own frequency of speech production and the modal voice. While the falsetto voice is produced when the vocal cord closure is not complete. There is some kind of air leak between the cords. So only the upper edge of the vocal cord vibrates and the lower edge does not vibrate. There is incomplete movement of the cover on the body. So this kind of produces a light voice. Whereas the modal voice, as we discussed, it is the basic frequency at which one phonates. Glottal fry happens when Dr. Siddhar radiates the patient. The cover body is essentially gone. The cover is not able to glide over the body. Because of loss of this gliding movement, the voice is not produced adequately. Of course, what we are talking about is the mucosal vein which is formed over there. So, how do we rehabilitate these patients? See, the mechanism of voice production is gone. So, there are multiple options. One option is that we give some new area of voice production. The other is that we give sound from some external source and we use articulators for speech production. And the best technique is of course tracheoesophageal puncture technique, where the lungs, we rehabilitate the function of lungs, we reuse it, and we use the vocal force of the pharyngoesophageal segment, the mucosal force of the pharyngoesophageal segments to vibrate and produce voices. So these are the things which we were talking about. So non-surgically what we can do, we can use esophageal speech and electrolarynx. And surgically what we can do neoglottic reconstruction, which usually we do for neonatal laryngectomies and all. And then we can use shunts. So coming on to esophageal speech. Esophageal speech was at one time the most common laryngeal speech technique followed. What the patients used to do was that they kind of swallowed air into the cervical esophagus. Then they will expel this air through the esophagus. This expelling air will cause the vibration of the pharyngoesophageal pharyngoesophageal segment, and these vibrations will produce sound. Eventually, our articulators will use these sounds to produce voices. But the problem with this kind of speech was that air has more, lung has more air volume. Esophagus does not have that much of space. So, by limitation of anatomy, when we are producing esophageal voice, we cannot expel that amount of air which lungs can expel. So, because of this functional limitation, the duration of speech production was very short. So, we could not produce long sentences or big sentences using esophageal voice. So, this was one of the major limitations definition of esophageal speech. But the advantage, what was the advantage of esophageal speech? Patient hands were free. So we know that with tracheoesophageal puncture, if we are not using a valve in the TEP side, which is expensive by the way, it has its own cost, the patient's hands are occupied. The other thing is that esophageal speech does not need any kind of additional surgery. But patients needed to be trained for that. And that training was really, not every patient was able to get trained with that. So there was some kind of failure rate associated with esophageal speech as well. Of course, the loudness and pitch control was also difficult. And as we have already discussed, that a patient could not speak continuously using esophageal speech. The problems, there were multiple other problems associated with esophageal speech. If there was cricopharyngeal spasm, there was reflux esophagitis, there were some other abnormalities involving PE segment. During surgery, there could be denervation of the PE segment. And of course, as we have already discussed, the patient needs to be trained, and if the patient is not properly motivated about this kind of rehabilitation technique, if the patient is not, if they are not able to educate the patient properly, it was a difficult modality to use. Cricopharyngeal spasm is something which can be taken care of, but still it was a problem. Then came electrolarynx. Electrolarynx is basically a battery operated device. It is usually held in the submandibular region, and it produces some kind of vibration, and this vibration, when transmitted to the muscles into the oral cavity, leads to sound production. When after that we use the articulators to produce words. So there are mainly two types. There can be neck type and intraoral type. Neck type is the one which is commonly handheld, and the intraoral type is usually where we can put it over the stoma, and we can use one pipe kind of thing to send the produced air into the oral cavity, and this also helps in production of speech. It has its own set of advantages. It is very easy to learn, very easy to learn. Immediate communication is possible. No additional surgical techniques is required. And many times when we cannot, as Dr. Karim had already pointed out, that in salvage setting, we many times do not go for primary TEP insertion. In those cases, electrolarynx can be a wonderful modality, and I think Mr. Mangajan will agree to this point. But it has its own disadvantages. One main disadvantage was that in post-radiated patients, the quality of tissue in the neck was not good, and even with electrolarynx, the vibration produced was not of good quality. So what are the other options? Neoglottic procedure and shunt technique. Neoglottic procedure had a lot of complications, so eventually it became a lost art. Shunt technique is something wherein we create a shunt between trachea and esophagus, and we divert the air from lungs through the trachea into the esophagus, and we use the PE segment as vocal cords to produce voice. There can be failures of shunt procedure as well, mainly because of aspiration to the fistula and closure of the fistula. So to bypass these things, prostheses were induced. So prostheses could be indwelling and non-indwelling. Indwelling prostheses are the ones which we commonly use these days, which is Provox, which we are using in our setting. And there was non-indwelling prostheses which was used earlier. We are not using non-indwelling prostheses now. So non-indwelling prosthesis is something which can be easily kept and removed by the patient itself. So tracheoesophageal prosthesis is basically a one-way silicone valve. It basically serves as a conduit, as we have discussed. It has got two flanges, one on the inside and one on the outside. Inside is on the esophageal side, outside on the tracheal side, and it has one valve inside, and it prevents the aspiration of food or liquid from esophagus to trachea. There can be primary TEP technique. There can be secondary TEP technique. Primary TEP is when it is done during the surgery. The tracheoesophageal puncture is done and the prosthesis is inserted. It has got its own set of advantages: single procedure, done in same setting, early rehabilitation, higher confidence, better education and training of the patient, all this. But some conditions are difficult to cater to with primary prosthesis, especially large resections, reconstruction with some kind of flap, salvage surgeries. So in those cases, secondary TEP is something which is preferred. It is important to understand how do we do tracheoesophageal prosthesis. So TEP is basically, it is performed in the midline, and the puncture site is usually made around 1 to 1.5 centimeter below the upper layer of the stoma, and the intervening tissue between the trachea and esophagus are punctured, protecting the posterior wall of the esophagus, and after the puncture is made, we put the prosthesis over there. We have discussed what are the advantages of a TEP. So important thing is to understand good patient selection. For TEP, a good pulmonary reserve of the patient is very important. And many of our patients who develop laryngeal cancer, they can have some problem with pulmonary reserve as well, because they might have some kind of emphysema, some kind of problem in the lung, some fibrosis, any kind of issues. As we have discussed, the contraindications for primary TEP are extensive surgery, patient is not psychologically prepared, patient has doubtful ability to cope up with prosthesis. This is a very important point. Of course, if the patient has impaired hand dexterity, if the patient does not have both hands, that is an obvious contraindication. We should, by and large, attempt for primary TEP whenever possible. It has got advantages of early rehabilitation, while the secondary TEP, which is usually performed 6 weeks following laryngectomy, it gives the patient time to develop esophageal speech also. So it has another advantage, that we can train the patient in this period for esophageal speech also. There are many kinds of prostheses which are used in TEP. What we are doing nowadays is Probox prostheses. Earlier Pranjay prostheses and Groningen button were used, which were kind of non-indwelling prostheses. But I would like to highlight these two prostheses mainly. This is one duckbill prosthesis which has got a large beak in front. This used to go inside into the esophagus, and the other was outside into the trachea. And because of its long length, it was kind of a high pressure system. Eventually, we shifted to Provox prosthesis, which is an indwelling low pressure system. It has an extended lifetime with proper and with clear maintenance, good maintenance. We can use it for a longer period of time. Both have their own advantages and disadvantages. The indwelling and non-indwelling processes. Indwelling processes can be left for 3 to 6 months. It requires a specialist to do the job. Less maintenance, more cost. While non-indwelling processes can be managed by the patient itself, but it usually has a very low shelf life. There can be problems with TEP insertion. There can be leak through the processes, leak around the processes. Patient can have immediate aphonia, dysphonia. There can be hypertonicity problem. There can be delayed speech. But before doing that, we have to ensure that the patient passes its esophageal insufflation test. And coming to the problems which we usually encounter with TEP is, of course, improper location of puncture site, inappropriate site of puncture site, cricopharyngeal spasm, leakage through the prosthesis. The location of TEP it is very important. It should be at 12 o'clock position of stoma. Should be 1 to 1.5 centimeters from tracheocutaneous junction. If we place it a little bit superiorly, the patient can find it very difficult to upload it. And if it is placed very deep into the trachea, it is very difficult for the clinician to take it out or put another TEP in the future, or to clean it. So the cleaning and maintenance becomes very difficult if it is put lower down. It is important to understand the management of leak through the prosthesis and leak around the prosthesis. If the leak is through the prosthesis, the solution can be, of course, replacing the prosthesis. But at many times we can also see whether there is some kind of fungal infection. We can try to treat it with this antifungals. We can try to see if there is some kind of other issue. Patient is not able to clean the prosthesis properly. And if the leak is around the prosthesis, there can be a problem related to the size of the prosthesis. We may need to put some kind of valve over there, or many times the party wall thickness can get affected. And in that case, we may need to resize it and replan our processes. I'm really thankful for all of you to sit so patiently and listen to this from a surgeon. And I would really also encourage Mr. Rukmanganathan to give his inputs also in this on this topic. Thank you so much for this. Thank you so much.